Kind of kicking off the PET course with non-oncologic indications, so I'm glad that they're getting much more widely used for non-oncologic indications, although of course the typical center will do the vast majority of their PETs for oncology. But there's been a real sea change in how we're using PET for dementia recently because of these amyloid-targeted therapies that have been approved. And so the informal survey of my friends and colleagues around the nation that amyloid PET is really being widely used now for the evaluation for these targeted approved therapies, and hence why I'm glad I'm getting the opportunity to speak to you about PET-CT for dementia. These are my disclosures. All right, but we're going to take a case-based format here, all right, because we're going to focus primarily on the interpretation of this imaging. And although amyloid PET is really coming on strong and fast as it appropriately has, FDG PET is still ordered frequently and is still a very powerful exam. So we're going to talk about both of them. And I want to teach you a systematic way of interpreting these things. I developed this over sort of many years, and it's more adapted to the way my brain works because I was having trouble learning it the way I think other people were kind of teaching it. So hopefully this will resonate with you. All right, so let's begin with a little bit of background information, the differential diagnosis of dementia. Alzheimer's disease is the most common form of neurodegenerative dementia, but is by no means the only thing you have to worry about. It is very appropriately gets a lot of press, but it's not the only thing. Vascular is often quoted to be the second most common cause in the United States. That is a non-neurodegenerative cause, but often present in mixed co-pathologies with AD, okay? They're not protective of each other, obviously, so as your patients get into their 80s and such, it's not uncommon that you'll have Alzheimer's disease and vascular, so you have a non-neurodegenerative mixed with a neurodegenerative etiology. Dementia with Lewy body is also quite common. And then there's a smattering of others, frontotemporal diaphasias, Parkinsonian dementia, chronic traumatic encephalopathy. I cannot teach you all of that within 45 minutes, but we're going to hit the top ones, and hopefully you'll be able to make the diagnosis around 90% of the time or so, the most common few there, which really do make up the vast majority of dementias. We focus on the positive causes. What about the differential diagnosis of dementia, or MCI, when it's a pseudo-dementia?
My talk on cardiac imaging is perhaps a little bit unusual because I was always an oncology girl, and I would have to say there are different ways of approaching things. And those people who do cardiac imaging, in my experience, don't mind the very rapid-fire, sure possibility that somebody can actually have a cardiac arrest in front of them. That was never so much my thing. However, I have, over the years, developed a very big appreciation for what we offer our patients in terms of cardiac imaging. And because my area was oncology, I came at it actually from the PET perspective. And PET adds a certain something to cardiac imaging, particularly PET-CT. So I hope I can convey some of this to you. How many of the people in the room actually do PET-CT in cardiac imaging? A couple of people. Okay, so let me go on and explain a little bit of why I think it's actually really useful. So here are my disclosures. So my objectives for this talk is why and how we started our cardiac PET program, so some initiation steps taken and how we justified it. That might be useful to everyone else in the room who may be considering getting into it. I'll also say a little bit of why now. Why now is it actually becoming even more important? So one, I believe that recently they have started reimbursing for myocardial flow reserve, which is something that is done far better with PET than with SPECT, meaning it's coming with SPECT. There's no question in my books. But with PET, it's already a little bit old hat, and it can add to what you do. Two, one of the problems with PET in cardiac imaging was always what radiopharmaceutical to use. I'll talk a little bit about rubidium and ammonia. Those are the two most common ones that are in clinical practice today. We basically use rubidium. However, flurpiridaz is coming big time, and that is an F18 labeled tracer, which will make it a lot easier to get it and to use it wherever you may be. So one of the other things I just wanted to mention is it's actually amazing because in the last couple of years, it's really become interesting just how many radioactive drugs are being approved and the speed with which they're being approved. So literally, we get a new one almost every 6 months nowadays. Technicas was just approved in terms of FDA approval. Flurpiridaz is expected to be approved within the next month or two, definitely this year. The phase 3 trials have already read out, and actually results were published at ASNEC, which was in the fall of last year.
I'm going to try to expand on tumor imaging with PET, especially in breast cancer, this afternoon. So, I'm going to try to cover PET in initial staging of breast cancer and detecting distant metastatic disease, also detecting recurrence in breast cancer. I'm going to touch a little bit on assessing response to chemotherapy and also neoadjuvant chemotherapy, which we use a lot in breast cancer. And, lastly, I'm just going to touch very briefly on non-FDG PET tracers for breast cancer workup. Okay, so appropriate interpretation of PET-CT, FDG PET-CT exams requires a very sharp knowledge of potential false negatives, which might result from, anything from small tumor size to low FDG uptake. So if we look at the AJCC 8th edition staging system, it basically includes two staging systems. There's anatomic stage, which includes the size of the primary tumor, the nodal status, and distant metastasis. And then it also includes a prognostic stage, which includes tumor grade, hormone receptor, oncogene expression, and the results of multi-gene panel testing to accurately predict a patient's outcome. One of the changes for breast cancer staging that was done recently is that lobular carcinoma in situ is no longer included as the carcinoma in situ category, but it's rather now considered a benign entity that may indicate a higher risk of future breast cancer. So that's not included in this talk. So this is just a slide that shows the AJCC breast cancer staging system, very familiar. I'm sure we all are with the TNM staging system. Tumor size less than 2 centimeters or between 2 to 5 centimeters or greater than 5 centimeters, which actually does make a difference in when to decide to use PET-CT for nodal staging. Regional lymph node status and distant metastatic status. So typically, we see that PET-CT is more and more used in, not really in initial diagnostic breast cancer anymore, more in follow-up of breast cancer and also in perhaps high-risk breast cancer patients, especially after stage 3A or further. Stage 3A is going to be your larger-sized tumors with local axillary metastases that are more than 5 lymph nodes and possibly chest wall metastases or local adhesions to the muscles and chest wall and perhaps locally to the bone, but not distant, and after that. So, PET, we know from the studies that we have done recently,